Hi friends, welcome to Pathology Riddles. Today we deal with acute pancreatitis. This topic will be explained in form of mind map. Please do subscribe and hit the bell icon to receive notifications of the new videos we upload. We start with the definition. Acute pancreatitis is a reversible pancreatic parenchymal injury associated with inflammation. The etiological agents are diverse and can be remembered by a mnemonic get smashed. So the causes or etiological agents are gallstones, ethanol or alcohol. These are the two most common causes. Then we have trauma, shock, mumps virus, atheroembolism, scorpion bite, hypercalcemia and hyperlipoproteinemia. ERCP. ERCP is actually a procedure. The full form is endoscopic retrograde cholangiopancreatography. This is a procedure to diagnose biliary and pancreatic diseases. And finally, drugs like azathioprine. So the mnemonic gets smashed. Coming to pathogenesis. There are three mechanisms causing acute pancreatitis. First one is pancreatic duct obstruction, commonly caused by gallstones and biliary sludge. When there is obstruction, the intrapancreatic ductal pressure increases, which leads to breaking of ductules in pancreatic parenchyma, which leads to release of enzyme-rich fluids in the interstitium. Most of the enzymes are inactive, but lipases are in active form, which causes fat necrosis. This death of adipocytes then stimulates the periacinar myofibroblast and leukocytes to release inflammatory cytokines and other mediators of inflammation that lead to local inflammation in the parenchyma, leading to leaky microvasculature and interstitial edema. The edema can cause impaired blood flow, leading to vascular insufficiency. This leads to, again, ischemic injury of the acinar cells. So that was the first mechanism. The second mechanism is acinar cell injury due to either alcohol, drug, trauma, ischemia, virus, etc. These cause oxidative stress, which leads to free radicals formation in acinar cells, which causes membrane lipid oxidation and activation of transcription factors, leading to again expression of chemokines, inflammation, and injury to acinar cells. This releases the intracellular proenzymes and lysosomal hydrolases, which activate the zymogens, leading to autodigestion of the cells and more acinar cell injury. Hypercalcemia in acinar cells can cause activation of trypsin, which will activate other zymogens, leading to more acinar cell injury. Coming to third mechanism. The third mechanism is defective intracellular transport. Usually the proenzymes and lysosomal hydrolases are transported through separate pathways. But in some cases, the proenzymes are inappropriately delivered to the intracellular compartment containing these lysosomal hydrolases, leading to activation of those proenzymes and acinar cell injury. All three mechanisms result in more acinar cell injury and release of activated enzymes, leading to interstitial inflammation, proteolysis, fat necrosis by phospholipases, and damage to vessel wall by elastases, leading to hemorrhage. These end results together constitute the acute pancreatitis. The clinical features include symptoms of abdominal pain, where the pain is constant and intense, referring to the upper back and left shoulder, associated with nausea and vomiting. Also note, acute pancreatitis is diagnosed after inclusion of other abdominal pain causes. The laboratory features include marked elevation of serum amylases during the first 24 hours, followed by serum lipases level by 72 to 96 hours after the beginning of the attack. Biopsy features can be divided according to the severity. Mild form that is acute interstitial pancreatitis, have no as such gross features. Microscopy will show mild inflammation, some interstitial edema, focal areas of fat necrosis in pancreas and peripancreatic fat. More severe form is that is acute necrotizing pancreatitis shows red-black pancreatic substance from hemorrhage and foci of yellow-white chalky fat necrosis. Also, the peritoneal cavity will have serous brown tinged fluid. Most severe form of hemorrhagic pancreatitis shows extensive parenchymal necrosis, extensive hemorrhage both on gross and on microscopy. Complications include acute respiratory distress syndrome, acute renal failure in severe types. Sterile pancreatic abscess and pancreatic pseudocyst are other sequelae. So, few extra points. CT scan is useful in the diagnosis of pancreatitis. Treatment is by resting the pancreas totally, by total restriction of oral intake, and by fluid or supportive therapy. Severe acute pancreatitis is a medical emergency and causes mortality in the first week in 5% of the cases. The systemic features in these cases are due to release of toxic enzymes and cytokines in the circulation, leading to leukocytosis, disseminated intravascular coagulation, edema, and acute respiratory distress syndrome. I hope you have understood acute pancreatitis. Do like and share if it helps, and do comment for more topics. Signing out until we meet again.